Hello everyone, in this class we'll learn about adrenal medulla. Adrenal medulla constitutes central 20% of the gland. Epinephrine, that is adrenaline, norepinephrine, that is noradrenaline, and dopamine are secreted by adrenal medulla. These hormones are called as catecholamines. Adrenal medulla secretes epinephrine and norepinephrine in response to sympathetic stimulation. Adrenal medulla is referred as a modified sympathetic ganglion. Mechanism of release of these catecholamines. Stimulation of preganglionic splanchnic fibers release the neurotransmitter acetylcholine, which stimulates medullary chromaffin cells by promoting inward movement of calcium. Then it leads to secretion of epinephrine and norepinephrine in the blood by exocytosis. Adrenergic receptors. Adrenergic receptors are divided into alpha and beta types. Epinephrine and norepinephrine both act on alpha and beta receptors, with norepinephrine having a greater affinity for alpha adrenergic receptors and epinephrine for beta adrenergic receptors. Alpha adrenergic receptors. They are sensitive to both epinephrine and norepinephrine. They are mainly excitatory except inhibition of intestinal motility. There are of two kinds of alpha receptors, alpha 1 and alpha 2. Alpha 1 are mainly excitatory. These receptors are located on the postsynaptic membranes, whereas alpha 2 are inhibitory, which are located on presynaptic nerve terminals of cholinergic and adrenergic nerves. Beta adrenergic receptors. They respond to epinephrine and in general are relatively insensitive to norepinephrine, and they are mainly inhibitory except excitation of myocardium. There are three types of beta receptors: beta 1, beta 2, and beta 3. Beta 1, its activation produces tachycardia and increased myocardial contractility because of the receptors which are located in the cardiac muscles. Whereas beta 2 is associated with the relaxation of the smooth muscle. In human, beta 1 adrenergic mechanism predominates. The actions of epinephrine and norepinephrine on the cardiovascular system, that is epinephrine and norepinephrine are powerful cardiac stimulants. They act mainly by interacting with beta 1 receptors and produces various effects as follows. They increase the heart rate, that is positive inotropic. They increase myocardial contractility, that is they are positive inotropic. They increase the velocity of conduction, that is they are dromotropic, and increases cardiac output, increases automaticity, and increase cardiac work and its requirement, and increase in excitability and tendency to cause cardiac arrhythmias. On the blood vessels and blood pressure, blood vessels on skin and mucous membranes predominantly contain alpha 1 receptors, hence are constricted by epinephrine and norepinephrine. Both epinephrine and norepinephrine also constrict renal, mesenteric, pulmonary, and splanchnic vessels. But epinephrine dilates blood vessels of skeletal muscle and coronary vessels. Via beta 2 receptors, norepinephrine does not produce this action as it has no beta 2 action. Intravenous administration of adrenaline in moderate doses produces typical biphasic effect. That is, there is an initial rise in blood pressure due to the alpha 1 activity on the blood vessels and beta 1 actions on the heart, followed by fall in blood pressure due to the beta 2 mediated vasodilatation in the skeletal muscle. Administration of adrenaline after alpha blocker produces only a fall in BP, that is which is mediated by beta 2 receptors, and this is referred as Dale's vasomotor reversal. The effect on the metabolism, that is carbohydrate metabolism. Catecholamines increase blood sugar via beta 2 receptor. They increase glycogenolysis by increasing phosphorylase activity via alpha receptors, and increase glycogenolysis by increasing intracellular calcium levels. Catecholamines via beta 2 receptor increase the secretion of insulin and glucagon, but they inhibit the secretion of these hormones via alpha receptors. On lipid metabolism, catecholamines by beta receptors stimulates hormone-sensitive lipase, which breaks down the stored triglycerides into free fatty acids and glycerol. In liver, excess fatty acids are converted into ketone bodies. On basal metabolic metabolic rate. Catecholamines increase BMR, that is, they have a calorigenic action in the presence of T4 and adrenal cortex. Epinephrine shows more calorigenic action than norepinephrine. On central nervous system, that is, catecholamine shows stimulatory effect on central nervous system, produces anxiety, hyperventilation, and coarse tremors and of extremities, and it is going to inhibit the release of antidiuretic hormone. On the eyes, the receptors cause contraction of the radial muscles, producing mydriasis. Beta receptors cause relaxation of the ciliary muscles and increase the tone of eye muscles. On the gastrointestinal tract, epinephrine causes decrease in the tone and mobility. This action is mediated by beta 2 receptors, and it also leads to sphincteric contraction, which is again mediated by beta receptors. Thus, it produces constipation. On the urinary bladder, epinephrine via beta receptors causes relaxation of the dextrosor muscles, and via alpha receptors cause contraction of the trigone and sphincters, thus produces retention of urine. For the skin, catecholamines via alpha receptor produce piloerection of the hair. On sweat glands, they produce localized sweating of palm and sole, which is called as adrenergic sweating. On skeletal muscles, it is going to improve the skeletal muscle blood flow via beta 2 receptor and increases force of contraction. On the bronchial muscles, epinephrine relaxes bronchial musculature, producing bronchodilation, which is again mediated by the beta 2 receptors. On the blood, epinephrine decreases clotting time due to increase in the activity of factor V. The increases RBC count, packed cell volume, and hemoglobin concentration. There will be increased plasma protein concentration. They cause increase in neutrophils. Some miscellaneous action will be initially they cause hyperkalemia followed by hypokalemia due to the increased potassium influx into skeletal muscle, and actions on dopamine. Actions of dopamine. Dopamine produces generalized vasoconstriction by releasing norepinephrine. It increases contractility of heart via beta receptors, and it is going to increase systolic blood pressure, and it does not affect diastolic blood pressure. On kidneys, it produces natriuresis by inhibiting sodium potassium ATPase activity, and it leads to vasodilatation. Because of these actions, dopamine is useful in the treatment of traumatic and cardiogenic shock. Regulation of catecholamine secretion. Secretion is entirely controlled by splanchnic nerves. These fibers are preganglionic sympathetic fibers and release acetylcholine as their transmitter. Splanchnic nerve activities are controlled by centers in the reticular formation in the medulla and hypothalamus. Adrenal medullary activation occurs as a part of sympathetic response to any emergency situations like fear, anxiety, pain, trauma, hemorrhage, and hypoxia. Secretion of glucocorticoids promotes conversion of norepinephrine to epinephrine, and hypoglycemia is a potent stimulus to catecholamine secretion. Some of the applied aspects related to adrenal medulla. Hyposecretion of catecholamines. It usually produces no clinical signs and symptoms because catecholamine production from sympathetic nerve endings appear to satisfy the normal biological requirements. Hypersecretion of catecholamines seen in tumors of chromaffin tissue called pheochromocytoma. Some of the features of pheochromocytoma are there is a sustained hypertension, headache, there will be sweating, anxiety, palpitation, and chest pain. There will be increased body temperature, there will be hyperglycemia, glycosuria, and there will be increased basal metabolic rate. There will be increased urinary excretion of catecholamines, metanephrines, and VMA, that is vanil mandelic acid. This is in brief about adrenal medulla. Thank you.